Welcome to Care Transitions Today, Case Conversations, a podcast presented by the Association of Physician Leadership in Case Management and the American Case Management Association, where we dive deep into the world of healthcare case management and transitions of care. Today, we are joined by three physicians, Dr. Rebecca Severe, Dr. Sweta Singh, and Dr. Teresa Jacobs. Dr. Rebecca Severe is a hospital medicine certified physician serving as Medical Director of Care Management for Advocate Aurora Health. With a focus on utilization review, quality management, and program leadership, Dr. Severe is passionate about evidence-based medicine and collaborative patient care. Her expertise and commitment make her a valuable asset to the medical community and a compelling voice in the podcast. Dr. Sweta Singh, Medical Director of Case Management at the University of Michigan Medical School, brings a wealth of experience in hospital medicine and a strong focus on quality improvement and patient safety. Her dedication to medical education and commitment to enhancing healthcare make her insights invaluable to listeners eager to learn and grow in the medical field. Dr. Teresa Jacobs is a clinical professor of neurology at the University of Michigan and is a distinguished expert in neurocritical care. Her wealth of experience in teaching and research brings invaluable insights to our discussions surrounding a variety of intricate case scenarios. In this series, we'll explore the challenges and triumphs of real-life case studies, providing valuable insights for healthcare professionals and anyone interested in the intricacies of patient care. Whether you're a seasoned physician advisor, a dedicated case manager, or simply someone passionate about improving healthcare outcomes, Case Conversations is your go-to resource for compelling stories and expert insights. This is Care Transitions Today, Case Conversations.
Hello, everyone.
Hi.
It's good to see you again.
Yeah.
Sweta, you had a case for us to start off. Is that correct?
And this is a more of a question while while the case is going, and I'll seek your advice and input on 2 points on this case. So this is a case that came in. It's a 48-year-old female with a past medical history of hypertension and well-controlled diabetes, no other medical illness, no current medication, who presented with bilateral lower extremity weakness, numbness, and urinary bowel incontinence. So in the ED, the patient was assessed and found to have this weakness. It was documented, so they did the MRI. MRI prelim report showed C6, C7, 13 by 14 millimeter positive signal and cord compression concern. So the neurosurgery was consulted. They planned on admitting this patient and then doing an OR eventually, but no data set up, and we tried getting an inpatient. The pair denied it, and this case came to our PA group 4 days after the admission. So patient came in on 28th, and next month 2nd is when we are reviewing this case. And again, we have a high capacity most of the time, so it's not surprising that our OR gets delayed, the scheduling time. Having said that, also we get a lot of the residents review the MRI initially, and the final report can take a long time to be posted. Now, so at this point, do you think would you go for peer-to-peer when you have a prelim MRI, patient already has been in hospital for 4 days and still waiting on the OR? Because it looks like patient, that's what the plan is.
Sweta, is the patient on Decadron? Typically, if you have cord signal changes and there's a question of any kind of cord compression as a result of edema, plus minus, that there might be some Decadron administered IV. Was that given in this case?
So it was given initially for first 24 hours and then switched to oral.
And okay, but there was oral Decadron going on. How frequent were the neurologic exams being performed?
So that's a good question. It was initially ordered Q4, our neuro checks, and later brought down to Q12.
And Sweta, clinically, how is this patient doing? And sometimes I find it's not always in the chart. Like this may be a detail I have to go hunting and talk to the frontline team. Like, are they still having those bowel bladder incontinence? How is their weakness? Any new neuro symptoms? What was going on there?
So no new neuro symptoms. Patient was stable,
Okay.
and nothing changed in past 4 days. What was keeping still the patient was the scheduling for the OR.
Mm-hmm. But I would have to say, Sweta, that if you're talking about definitive imaging that says that the cervical cord is impacted, so much so that we know the patient has symptoms of weakness and bowel bladder dysfunction, then you definitely have a risk profile here that is rather high for the patient. In my mind, it would be unsafe to send this patient to an outpatient situation. So whether or not we fall on the sword and eat the payment for this or not, the best thing for this patient is, and sorry, I'm wearing my neuro hat here, but the best thing for this patient is not to be discharged, because I have seen patients in the past, even if they're being treated with Decadron, develop enough edema swelling that they end up paraplegic or worse. So in my mind, the patient would need to be definitely continue to be evaluated with neuro checks. It's unfortunate they went down to 12 hours. Sometimes, though, I'll look in the nursing notes and find out that, an order may have been placed for 12, but in reality, especially if the patient's on a neuro floor, those checks are still being done Q4. So that's something else that you could do, is look in the flow sheets to see what was really happening.
Rebecca, do you want to add anything?
Yeah, oftentimes this is another opportunity to reach out and I'll just talk to the clinicians. I'm like, where do we think this is going? And ask the neurosurgeon, is this a patient? I mean, to me, I'm not a neurologist, neurosurgeon. To me, it feels like if those neurosymptoms are still persisting and it's from cord compression, like this patient needs surgery soon, like now, like what can I do to help expedite that? But really getting that in the chart, like getting the surgeon to say this needs an urgent emergent, surgery. It must be done this day. It's not safe to discharge, and, have them come back at a later date. But just getting that kind of language in the chart, I think can be really powerful in making the case. And then my other thing that I do is work on, like, why do we have so many delays? Like, what can I do to help with that? Sometimes just a little bit of a push, especially if someone needs something urgent, you can escalate to someone within the organization, especially sometimes the frontline team just gotten so used to delays that they need your assistance, and that can be a win too. So I don't know, where did you guys end up, how long when were they going to do the surgery for this one? Like, how much of a delay did you have?
This came to our PAs on October 2nd, and in the initial review, the physician advisor was like, if this patient truly needed an emergent surgery, why didn't they take into the OR 24 to 48 hours? One of the barriers they can see clearly is that they'll say, why keep in hospital still 4 days? Then this could have gone to the OR within 24 hours, gone through the post-op period, and then it's like there would have been more to say in terms of what was done for the patient. And because of that, which not necessarily I totally agree with, the plan was made, let's see what happens with this patient. But, and then 2 days later, patient did end up undergoing the surgery, decompression, C3 to T1, followed by neuro ICU, had infiltrated IV during OR, so plastic surgery was involved. There was a lot more happened, but by the time this happened, we lost the window to do the peer-to-peer. So we had to go through the appeal, and it was like, it was obvious this is an inpatient level of care. But what I wanted to bring with this case is the points that you rightly brought up, Rebecca. A lot of time being in that position, we can identify, these delays, reach out to the team, 3, have them document what's keeping the patient still in hospital. Why is there a delay? If it's a clinical delay, sometimes, like Teresa said, there can be significant amount of edema that they want post-decadron to go in before they just jump in. And having that clarity of the thought process and just initiating the discussions, because this would have been, by the time peer-to-peer got scheduled, we would have had enough events or documentation support to have that discussion. Would have been like ideally the way I would have liked this case to go.
Yeah. My only other comment here is I think we need to be very careful as physician advisors to not make clinical judgments. We need to get the information that we need to get to proceed forward. But obviously, the neurosurgeon here felt that with the addition of steroids and the current examination of the patient, and I'm sure they were looking at the patient, they felt that they could wait the additional time. And they did, and then they had a successful operation. And with OR capacities being what they are, sometimes it just cannot budge. But I think Rebecca's idea of having a conversation with the surgeon is a good one. And again, I would also want to see documented, or for myself, find all of the little nuances that are in the chart that could be made about the argument. And I would never, as the PA, presume that I understand necessarily what the thought processes in the medical decision-making is by the attending of record, such to say, oh, this is observation. I would not do that. I would err on the side of inpatient, but before I would call them and have that conversation.
Yeah, because I've found cases where I'm like, what's the delay here? I don't understand it. And maybe it's, like you said, they need the edema to go down and they want to wait several days, but it's just not in their note. Or they had a dose of, they were on anticoagulation and Plavix or aspirin and they want to wait so many days. But again, they didn't really highlight that. There was really good rationale. Or sometimes with these back cases, the MRIs can look bad, but sometimes they don't always want to go to surgery if they don't have to. So sometimes there's that waiting and seeing if there's any clinical improvement. And sometimes that delay is intentional. So I think those are those nuances, again, not being a neurologist, neurosurgeon, that I may not see. And I just need like 2 sentences from my surgeon in the chart. And that can make all the difference. And the other thing I was thinking of too, is that sometimes with these cases where I know, we've got a short turnaround time for my, the peer-to-peer, but I've got a procedure and I know if that procedure happens, I've got a slam dunk inpatient. I will time that just so. Sometimes I'll request my peer-to-peer late in one day so I get it in the window, but knowing they're not going to probably call me back to the next day, but by then we'll know for sure they're having the surgery. So I have intentionally done that just to help solidify that inpatient, but not get out of my window. So sometimes there's some games you can play with the time frame to help you out too.
That's a very interesting perspective, Rebecca, and I'll have to remember that too. So, and hopefully we'll have to write the denial letter, obviously, but it sounds like there's no way that they're not going to back down on overturning this. It just really sounds like, the whole stay in total just screams an inpatient. So.
Right.
Yeah.
Absolutely. I think my main aim to bring it is this is an inpatient, but that what Rebecca rightly said, sometimes we have to time the peer-to-peer so we have enough. And I think peer also wants to have a more meaningful discussion and value for their time. So they want these peer-to-peer to happen when we have the most information as well. And that conversation with the primary team for documentation, like sometimes it's okay for a patient to get the surgery within 5 to 7 days. It's safe, but then still not safe to be discharged because they need to monitor that or have that neuro checks in case if things change. And having that clear documentation definitely helps.
Yeah.
That was my case.
Oh, thank you, Sweta.
Thank you.
The Association of Physician Leadership in Care Management, or APPLECOM, was created to provide support and education for physicians in this field. APPLECOM is unique because of its connection to the American Case Management Association, focusing on the partnership and collaborative model of nurse case managers, social workers, and physicians in care management. ACMA has a rich 25-year history of supporting the case management field. AppleCom is inclusive of all practice settings. Membership in AppleCom also gives you access to all ACMA resources and benefits. Whether you're new to case management or have years of experience, AppleCom membership is valuable. Gain access to professional networking opportunities and resources. Visit www.applecom.org to learn more. Case managers. Join thousands of your peers who have made the decision to further their connections, learning, and knowledge through ACMA membership. Access the Member Education Center with recorded webinars, CEs, and peer-reviewed articles 24/7. Visit www.acmaweb.org/membership to learn more. Let's continue with our next case.
I've got a short one for our second case today. So this one we'll have to shift. It's a traditional Medicare case. So we have a 71-year-old female, history of hypertension, chronic kidney disease, stage 3, diabetes, had aortic and mitral valve stenosis along with a aortic valve replacement as a tissue valve, and a mitral valve was also previously replaced. This was done back in 2022. So the patient had all this valve stuff done a couple years ago. And this patient had had several hospital stays over the last couple of months, had one for CHF, another one in between that was for a fall and back pain, so not related to the valve or heart issues, and then a subsequent visit, all about in a 2-month span, having CHF, some AKI. And, as part of that workup, they had noted that this patient was having severe degeneration of their valve. Their aortic valve, and they, or at least based on the studies they had done a TEE. They were seeing some high, the flow and restriction, and so they had decided to have this patient get set up for a possible TAVR procedure. And so this is all of this is going on within a 2-month span for this particular patient, and the patient comes in for the TAVR. They go to the OR and they have, anesthesia starts. They have femoral access going. They're doing the TEE, and they note that the peak gradient across the valve was not what they thought. And so they're like, oh, we don't have to do a TAVR. And so they ended up aborting this TAVR procedure. So this comes to our team as part of, we have what we call a short stay work queue for all of our Medicare cases that they don't get billed out until our nurse reviews, and then they go to the PA. A lot of them will go to the PA for that second look before we either let them go out as inpatient. The nurses, if they see criteria that and we have a list of things, they can bless it to be billed out as inpatient. If it doesn't meet the criteria, it does require the physician advisor to review. And so this one did come to our physician advisor team to take a look at, because it was a really short stay, only a few hours, and they didn't do the procedure. So I guess do you guys have similar process at your hospital? And if so, how do you handle cases like this? And
you'll have to remind me, Rebecca, but the TAVR is not on the inpatient only list, correct?
It is. But again, they didn't do the TAVR. They were going to, but they didn't do the TAVR. They just made it as
they didn't bill it out as an inpatient only code then, I'm assuming.
Well, that's my question. What do you think about that issue?
Well, I think if they didn't do the procedure, they shouldn't bill it under the code. That to me seems not to be legitimate. And in my mind, they did do something though, and they will need codes to correspond to what they did with the anesthesia, with the TEE or whatever else they did under anesthesia. So I think you would bill for those things, but you could not bill for the procedure. Otherwise, at least in my mind, I don't think it would be right to do that. But I don't know. Sweta, what do you think?
So if I remember correct, I think I remember reading an article about it. If a patient is planned for an inpatient only surgery, comes in, and that's where I vaguely remember. So correct me if wrong. If they start the procedure and anesthesia is started, but for any reason it's aborted, say patient develops COPD exacerbation or declines with the anesthesia and they had to abort the surgery. If it's an inpatient only procedure that they planned for and they had the inpatient order, they could bill it as an inpatient. Having said that, again, because at the end of the day, they had all the right people still there, their time being used up and being there, present there. But from billing and coding perspective, I'm not the expert as to what exactly CPT codes or procedure codes to bill for. Um, and from that perspective, I think they could bill for the anesthesia and the TEE part. But for level of care part, that does get interesting as to inpatient or not. And if there was an inpatient order and an inpatient only procedure was intended and anesthesia started, then we could bill them as an inpatient. In terms of process, Rebecca, we have a very similar process. For all those short length of stay, they get reviewed, and if a patient has an inpatient only procedure, then they are just reviewed by the URRN. We don't need to, and the surgery went fine, procedure went fine, and it was inpatient only. But if it something like this case scenario where surgery did not complete, it did not happen, or this was not an inpatient only surgery and patient just stayed for one midnight for whatever reason, was admitted, then they will send it for secondary review for physician advisor review. So we also do review before we bill all our Medicare short stay patients.
Yeah. And I think these are tricky because I know some of these, it doesn't feel like we did it. It feels like we shouldn't be billing for an inpatient only. And they did access the groin. And again, I'm not a cardiothoracic person or a interventional cardiologist. So, but they did start the procedure and they got partway into it here, but they didn't, after accessing the groin and doing their TEE, they decide not to. So there is a special billing code to put on these inpatient onlys if you actually start them and abort them. I don't know exactly how they get billed out. I don't think you get the full amount of the payment for it. There's some way they work that out, but there's a way to indicate to our payers, that follow the inpatient only that we started this, we aborted. And so with these, in general, I leave them inpatient. I oftentimes, if I have a question about exactly what happened and how it's going to code out, I do loop in coding because they can be very tricky. There are some that I think are a little bit easier to say, oh, no, we aren't going to bill this out. Those are the ones where they do have a planned inpatient only surgery. They'll show up to your pre-op area, for example, and maybe it's like a knee revision. Let's take that one. Pretty common, right? But sometimes, even though they have their PAT nurse calling ahead of time, the patient shows up and, anesthesia, the surgeon looks at the knee and they're like, oh my gosh, this patient's got a cellulitis over the knee. Like, we have to stop the surgery. Like, they get as far as, maybe getting an IV put in and some labs and then everything is canceled. Those are ones I feel very, very comfortable about saying no, that nothing started. They were not in the OR. But in general, if they're wheeling in the OR and that anesthesia starts, for me, that's usually where I'll say that procedure has started. Now, there could be some exceptions to that, but in general, if you've got a planned IPO, inpatient only surgery, and make it into anesthesia and you have to abort. I've had some they went AFib RVR, for example, and didn't get very far, but that was still the planned procedure. Again, we bill those out, we put that special code on, and it should work. It should not be seen as fraud. Certainly, go ahead.
I hope I didn't misstate this. I didn't think it would be fraud to bill it inpatient.
Yeah.
I just think that my level of comfort would be, let's try to accurately reflect what was done in the billing. But again, that goes back to billing and coding.
Yeah, I definitely think for these, reach out to have a coder on speed dial. If you're a PA, know your coders at your site, because these are tricky. These are the hard ones. And, I definitely, if I wasn't sure, I would we're leaving this inpatient. I reach out to the coding team, ask them, and then we can always do a rebill if that's the right answer. If they're like, no, if there's nothing that's going to code out to an inpatient only, you can do your rebill and, make sure, again, you're being compliant. So.
Absolutely.
That's a great case, Rebecca. Thank you for bringing it to us. Yeah. So I think we're done with another session, folks.
Yeah.
Yeah.
Good to see you all.
Great discussion.
Thank you.
Thank you.
Thank you to everyone for joining us for another episode of Case Conversations. We would also like to thank Drs. Sabir, Singh, and Jacobs for sharing these interesting cases in these episodes. We would love to hear from the audience. Please join in on the conversation by visiting acmaweb.org/podcast, and don't forget to subscribe so you're notified when we upload new episodes. Until next time, this was Care Transitions Today, Case Conversations.